Wonderful. Welcome. Thank you, everybody, for coming to Notes on the Sideline podcast and YouTube channel. I'm your host and content creator, Safdar Khan. I would love to introduce our host, but before I do that, I have to do my customary disclaimer. All the thoughts on this podcast are my own and do not reflect the official position of my employer, The Ohio State University. This Notes on the Sideline format is really to bring together coaches, players, parents on a format like the Sideline where we can have genial conversations about this sport that we love. It is my absolute honor and pleasure to introduce our guest today, Dr. Larry Nolan. He is the head team physician at The Ohio State University, takes care of the men's hockey, basketball, and golf teams, as well as the women's cheer and gymnastics team. He is a concussion expert and is an assistant professor in the Department of Family and Community Medicine. Dr. Nolan, thank you so much for taking the time out.
Thank you so much for having me. Really appreciate it.
Well, our topic today is discussing a condition that has really been brought to the forefront of the public's attention, that of concussions. And obviously the NFL is on now, Premier League is on. We hear a lot about our professional athletes having concussions, and especially with what happened with Tua Tagovailoa a couple of weeks ago. I think this is bringing more attention to concussion. So at a very high level, Dr. Nolan, what is a concussion?
Yeah, so concussions are, we see them in a lot of different things, so, kind of focusing just on sport-related concussions. We consider it basically a traumatic brain injury that is caused or induced by biomechanical forces. And so a lot of different symptoms come along with it, a lot of different presentations, but it basically can be caused by either a direct blow to the head or a indirect blow, so somewhere to the face, the neck, the body, and those impulsive forces are kind of transmitted up into the brain. And so we often, think of some of the bigger hits, like you mentioned Tua recently in the media. I think, one of in my head, Javid Best, when he was at Cal, unfortunately, that video always kind of sticks out in my mind. And, we think of these big hits, but sometimes it can be, a very benign hit in the game of soccer. Sometimes someone comes down from a header and, feeling a headache, feeling nausea, feeling something different. And so it's not necessarily from the ball hitting the head or the skull hitting another skull or helmet to helmet or anything like that. It's the rotational forces that get exerted on the brain within the skull.
So what would you say then is it age specific? So in other words, is a U6, U7 player with a developing cranial box at a higher risk of a concussion, or is someone who's a little bit mature, U17, U18, college age, more susceptible to the same impact leading to a concussion?
Yeah, so it's a little convoluted, right? So, like you mentioned, it's pretty popular in the media, which means it's also going to be popular in research. And so we're all looking and trying to kind of assess and figure things out, what causes these concussions? Why does, 1 6-year-old that runs into a ball or runs into another player get it and another 6-year-old doesn't? Why does, some big tackle cause a concussion and then the next small tackle, necessarily doesn't, even though, they hit the ground equally hard? And so I think, the developing brain definitely is a little bit more, and I hesitate to use the word fragile, use it just because we see more protracted recoveries. We see that in the younger population. And so, compare maybe a 25-year-old soccer player compared to a 15, compared to an 8-year-old, I would anticipate the 8-year-old to have a lower or a longer recovery, just because of a number of variables, one of which being the developing brain. Now, that also comes with incidence of concussion changes. As we get older, we're also spending more hours on the pitch. We're spending more hours of practice, more hours in games. It's a little bit more, I don't want to say athletic, but the game speed has increased, right? So too has the skill set. And so now you're talking about more, not just more impacts, but maybe relatively harder impacts. And so really the biggest thing we see is just that volume of exposure. The more athletic exposure you're getting, you're increasing your risk for concussion.
Gotcha. And how does a concussion present? I'd like to break it down to maybe on field. what the first maybe hour looks like, and then maybe within a day, within the evening, if the game occurred in the morning, what does the first hour look like, and then what do coaches need to look for, and then after about 12 hours in the evening at dinner time, what do parents need to keep an eye out for?
Yeah. So unfortunately, extremely variable, but I think having a high suspicion is the first step. And so, you see the student athlete or the player gets maybe the impact, right? That head to chest or head to ground, and comes up and says, "Hey, my head hurts." Okay, so you're already kind of thinking, okay, something's abnormal here. But sometimes they won't even initially complain of something. They might continue to try to play for a little while, and then you, the parent or the coach or a referee, are noticing, this player is not acting the way they were 20 minutes ago, 15 minutes ago. And so that's a time to kind of, use one of our cliches. We have the phrase, when in doubt, sit them out. And so if there's any suspicion at all, go ahead and pull them from that activity, because we want to protect the brain, right? You only get one. And so we want to be on the side of caution, especially when we have suspicion. But the wider range of symptoms in that first hour can be usually headache, dizziness, nausea, those kind of more acute feelings of just something off, or I just feel like I'm in a fog. I'm not feeling, the player might use the phrase, don't feel quite right. And that's what you're going to see in that first hour. But like I said, sometimes student athletes or players won't have any symptoms for several hours. And so that suspicion needs to remain. And so later on at dinner, hey, my appetite's not there, or maybe you're noticing them be a little more irritable than they normally would be for sitting down at the dinner table. That nausea is persisting, the headache's getting worse, those kinds of things kind of continuing. And then as you get into the next, those later hours up into the 24-hour period and beyond, you're going to notice more of those symptoms that kind of maybe are always present, but are worse, right? And so, hey, I'm tired because I didn't sleep very well, but now I'm really fatigued. I'm not making it through the school day, or, I'm still really dizzy. I'm okay when I'm sitting here, but when I change positions, I get up out of the chair, it just doesn't feel quite right. And again, we use that phrase, in a fog. I think, a lot of student athletes, it's funny because, they've never had the concussion before. They don't talk to other people with concussions, but they consistently will come to our office and say, I feel like I'm in a fog. And so those are the kind of the things I think that from a player, coach, parent, and referee, kind of that first 24-hour period. But again, just keeping that clinical suspicion high. And if you have any concern, especially after that 24-hour period, for a lot of those big symptoms, that's the time, you want to reach out to us, get seen, have someone take a look at you, get evaluated. Fortunately, both in this area and around the world, soccer is a huge sport worldwide already, right? Yet it's still growing, not just in America, it's still growing worldwide. And so with more publicity and more people playing, we're going to get more athletic exposures and more risk of concussion. But also, it's our job to kind of continue that education. And so making sure referees, coaches, and parents are all aware of those symptoms and kind of keep a high level of suspicion.
And so that, and I know we were talking offline before about how important it is for youth soccer clubs or tournaments. I know for sure for tournaments have athletic trainers, but even for that one-off league game, should there be, if not a designated trained individual, but also you had mentioned the pathway. There should be a pathway where if there is a concussion event, where there is a ease of access to yourself, to your
Right.
team members. Talk to me a little bit about your philosophy behind that and how youth soccer administrators, club administrators, coaches can build that connection with specialists like yourself.
Yeah, absolutely. I think it's huge. I think, prevention is key. We can unravel into healthcare in general and, why we want to have more prevention. As a primary care physician, I'm big on, preventing as much as we can. And I think establishing those relationships and, like you said, opening up those pathways, those doorways is crucial. And, there's enough of us around, especially, here in Columbus, there's so many of us sports providers that are trained and able and willing to help student athletes. I think it's a misnomer that people think we're the docs that hold student athletes from games. No, like our job is to put people back on the field. That's what we like doing. And so I think if you have access to an athletic trainer, they should have access to a physician, and that athletic trainer can be a huge resource. We're very fortunate with athletic training here in this area. And so if you have that relationship, utilize it. If you don't have that relationship, have your administrators talk to coaches, talk to the administrators, reach out to those of us, in the area, and get a relationship. That way it's a phone call, or it's set up. So if you have some injury that it does occur, you're already prepared for how to fix it.
Yeah, I mean, I think that's really key, especially in my conversations. Reaching out to multiple large clubs in the Central Ohio area, is even if there's a 1-800 number or a phone call or a contact person that parents can just go on the website and say, you know what, they're a student athlete, she's not acting right, or there's a fog, or after 24 hours there's irritability, headaches. Instead of saying who should we call, there is a pathway out to a concussion clinic or a concussion specialist. So that's definitely something to pitch to our youth soccer administrators. What would you say, just to the medicine naive parent? What are the treatments available for a young a student athlete, young woman or young man who maybe is in the age U11, U16 age range, who has sustained an on-field event, is demonstrating the signs of a concussion 24 hours after the event? What is your program, and how do you counsel parents and the athlete? What are the treatment steps?
Yeah. And so I think first and foremost is preparation and education. And so if we, hopefully listening here tonight and listening other times, you kind of take the first steps upon yourself. And so when in doubt, sit them out. So you've taken the athlete away from the ability to potentially get further injury, right? And so relative brain rest, meaning just take it easy. It's easy when it's an ankle and someone hands you crutches and they tell you not to walk on the foot, right? But I can't tell you not to think. I can't tell you to turn the brain off, but really just avoiding things that aggravate it. And so a lot of times, the student athlete will complain, oh, lights really bother me, sounds really bother me. Okay, well, let's take you out of the lights. Let's get you out of the noise of the game. Let's get you home. So it sounds simple, but really just, if it's bothering them, don't let them do it. Get away from it. I encourage them. They can still watch a little TV. They can text on their phone. That's fine. But if they get a headache after texting for 20 minutes, get the phone away, do something else, get away from it. Same thing. They can read a little bit if they're bored that evening, that's fine. But if they get a headache or they feel dizzy, get away from it, try to do something else. And so the relative brain rest is the first thing. If the headache is the biggest symptom, Tylenol, acetaminophen is a great first medication. I kind of prefer to avoid using some of the non-steroidals like aspirin, Aleve, Motrin, those kind of medicines that are also available over the counter. Just a slight relative bleed risk, and can also lead to rebound headaches if we use them too much. But those are things that the parents can do right out the gate before they even get to our office and be seen. Once they are getting seen in our office, one of the biggest things is to know that concussions are kind of like snowflakes. If you've seen one concussion, you've seen one concussion. And so, we're going to have a different treatment plan for, Jimmy versus Sarah versus, maybe Sarah's unfortunate second trip. Every time we're going to have a different treatment plan based on their constellation of symptoms, based on the severity of their symptoms. But the biggest thing will be kind of just giving that brain a chance to rest initially.
And how do you what's the time frame for allowing that athlete to get back into a contact sport like soccer? What's the time frame between the onset of treatment to the onset of returning to the pitch?
Mm-hmm. Yeah, so it'll be a little different. Again, we see, we used to tell everyone 7 to 10 days. I think that data is a little not expired, but it continues to evolve as we get more and more information. I think for the majority of our younger, using that U11 as an example, I'd probably anticipate a 2 or 3 week recovery. Again, everyone's going to be a little different. And that's probably true for that high school age as well. When you start getting in those protracted recoveries, those 3, 4 weeks, 5 weeks and beyond, then, there's obviously going to be some other medical care going in. But in general, we expect most people to be around that 2 to 3 week mark. and inclusive of that will be a minimum of 5-day return to play. And so what that looks like is 5 days of increasing exertion. So in my mind, they're student athletes, at whatever level, even if it's kindergarten or, up to the collegiate age, it's still, so I want them basically to be 100% themselves, 100% a student, and then 100% an athlete. And so that athletic piece will be the last piece. Hey, you're feeling great. Your symptoms are gone. Let's kind of stress this out a little bit. And so putting them on, a light aerobic activity, have them walk around the field, kind of have them start jogging into the next day, and then some soccer specific stuff, touch the ball around, but not getting at risk of having to perform a header or getting any contact. And then as that 4th day comes around, okay, now it's a little bit of non-contact practice. Okay, it's a full-on kind of soccer scrimmage, but I'm just not getting hit. And then the day 5 would be that full-on regular practice game scenario. And that what that shows us is that increasing exertion, that the ability for that cognitive and that physical components of the brain to not be reacting and not getting worse. It kind of shows us, hey, this person's recovered, this person, it's safe, most importantly, for them to go back and return to play. So in general, 2 to 3 weeks.
And that's very helpful, actually. What happens if the athlete fails at each time point? And do the symptoms of concussion evolve and vary? So could they get worse with time, get slightly better, then worsen? Could there be sort of rhythmic expression of symptoms?
Absolutely. Yeah. I think, and that can be frustrating both for, the athlete as well as the parents. And honestly, for us, we want people to be better. We want people to be back to playing soccer all the time. But yeah, so up and down, I always say you're going to have good days and bad days. That's perfectly fine, as is normal life when you're not concussed, right? Good days and bad days. But as long as the overall trend is improving, then I feel pretty confident you're on the right track, and there's no need to kind of change the course. But, certainly if you have a series of bad days or the direction's changed, then maybe that's the time to kind of check back in or get reevaluated. But also, if let's say you fail on day 4, you're out there, you're doing some, you've passed the cone drills and now you're dribbling around, you're hitting the ball a little bit, and, you start to get some symptoms. It doesn't mean you have to come back and see us, doesn't kick you all the way back to day 1. In general, it just means you got to wait a 24-hour period and retry day 4 again. So that's why, in general, I say a minimum of 5 days to return to play once that process is started. And it'll be a little different for every sport, but soccer is actually it's one that makes, I think, sense to me at least.
Yeah, they have started as per protocol for youth sports. We cannot head at U10. U11, we can start heading the ball. What is your opinion about that? Number one, and number two, is heading dangerous? Is heading the ball consistently during a 60-minute game? You probably head it 5-6 times at most. Is that something that needs more attention, or what are your thoughts about that?
Yeah, both, I would say, and I would emphasize, as we did at the beginning, this is, my personal opinion, but I think what we call is purposeful heading, I don't have any problem with at any level. I think the rules are well intended. I think it's a great idea to limit athletic exposure or limit the risk of injury is always, in general, a good thing. My hesitation comes in, and I think it makes sense, right? So the data said, hey, we're getting concussed. Let's avoid concussions. And so people under 10 and then 11 to 13 will kind of limit them. And then, hey, 14 just go crazy. My hesitation with that is I want to teach the athletes how to head properly. I want them to have the technique. I want them to know what it feels like. So I really feel like it should be on the coaches and the athletes to learn how to properly do it as we go along. That being said, I mean, the data varies, right? As we, depending on the country or the time period, et cetera, as awareness is increased for concussions, we see more concussions. So that's because there's more people aware of it to actually diagnose them, right? But we don't see a ton in any of the literature really that has supported that ball to head contact from a header, from purposeful heading, has had any correlation to concussions. The vast majority of concussions in the soccer field occur from head to head, head to body, or head to ground. Certainly, if would I be signing up for being in the wall and having someone shoot a free kick at me right in my head 12 times a game? Probably not. But do I think that 12 clears purposely at the defensive end, or 6 shots on net with a header? I don't see an increased risk there, and I think the data supports that.
That's actually really, really, really helpful. Is it, now I've noticed as our young athletes are learning to head, is there something coaches need to be aware of in terms of how to properly teach heading the ball? I've seen some kids jump up and hyperextend their
I think
try to get the ball versus those that are in a neutral position or who are facing the ball when they head it. So it's really purposeful on the front end. What, for the layperson, for the parent on the sideline, what is the best way to teach your young athlete to head the ball?
Yeah, I always thought it made sense to me, and this is the way I was taught, was to head the ball and not let the ball head you, right? And so I think it is, as they age and they get more athleticism, are they able to kind of have that where they're redirecting it in midair and not having to go directly forward on. That skill set is a higher, but at the lowest level, I think it's really just placement, right? Trying to get it on that, kind of that hairline, so to speak, and making sure that they're going through it. And then also not stopping with the ball, right? And so making sure you're kind of going through, similar to exactly how you kick, right? You don't just stop your foot at impact. I want your head to kind of go through it, because again, you're heading the ball. And that allows on a basic level, the forces you're exerting them, right? So they're not unexpected. And I think that prepares over time to be more protective.
Very helpful. Thank you, Dr. Nolan. And is there any one, I mean, I guess if we were to, sort of free think this, I'm assuming, again, this is just a parent assuming that the goalkeeper position is at higher risk of a concussion. Is that true, or is there any other position in the literature that is shown to be at greater risk of having concussions in soccer?
Yeah, I think it's interesting. Anytime we look at epidemiological data for soccer, or for any sport for that matter, but within the world of concussions, it's going to vary on where you were and when you were, right? And so, because one, the game has evolved, right? The game is different than it was in 1998 and 2008. The way concussions are diagnosed is different. The way concussion recognition is also different. So you have all these other variables. In general, I would say that the field players have a higher incidence than the goalies, but I think it comes down to, again, more exposures. Relatively speaking, if you take out corner kicks, set pieces, the goalie isn't usually in that much collision, whereas in the middle of the pitch, you're going to have relatively higher there. I will say, though, the more significant injuries, so now we're talking outside of concussion, those head injuries that result in hospitalization or otherwise, the literature has suggested that it's to goalposts or within the net. So the goalie being there more often.
Yeah. Okay, awesome. And then is there any, what would you say is the latest research on concussions in the youth athlete? What are we looking forward to as we wrap up our conversation? Is it what does the next 5 and 10 years look like in terms of concussion research for the youth athlete?
Yeah, I think for the youth athletes especially, I think we're going to continue to see rule changes. I think, and what'll be important for us is to recognize whether or not those rule changes are effective. And I mean that because, if we do, if we look at data from a point A to point B, but the rule change happened in the middle, and we're looking through that, we're kind of comparing apples to oranges. And so I think, as let's be honest, it's in the media as we see these kind of headlines and things pop up. I think it's on us to kind of taper expectations and kind of make sure people are aware of what actually the data is suggesting. But that being said, I think you're going to continue to see, with the awareness and people more on the sidelines, I think you're going to get away from kind of the old. The initial concussion data was always emergency room driven, and kind of a very subspecialty group of patients, where I think you're going to see more databases, more collaborations between US soccer and youth soccer and all these organizations now that are taking it upon themselves, which I think is great, to create these databases so that we can use where are we can get a true sense of where we are, and then we can truly make an impact going forward.
Well, this has been incredible, Dr.
And I
Nolan.
guess to better answer your question, I think we're going to figure out
Yeah.
what's happening and why it's happening.
Yeah. Well, I can't thank you enough. This has been phenomenal. Just as an overview of concussions, I know it's a deep topic and a very extensive science. We're very privileged to have you give us an overview of what concussions are, what type of injuries they are, what are the initial signs and symptoms of a concussion, what are the things that our coaches and parents should keep an eye out on the youth athlete, immediate care on the pitch, and then what to keep an eye out for over the following 24 to 48 hours, when to contact a specialist, the role of the specialist in games, and how we can connect parents with healthcare providers as quickly as possible. And then you went over a little bit of the concussion protocol. Once patients come to you, when the concussion athlete comes to you in clinic, how you treat those patients, and what the paradigm and the time to return to play and return to school is. We talked about concussion prevention, sport and position specificity with concussion in youth soccer, and then finally what the research looks like in the future. Is there anything else, Dr. Nolan, with great gratitude, that you'd like to tell our coaches or our parents or our referees that may be accessing this podcast?
Yeah, just thank you for everything that you do. I think, I certainly am a biased opinion here, but I think sports are awesome, and I think it's great for the developing young student athlete, and I think it's great to continue utilizing it. They can't do it without endless thanks to those groups. So just keep doing what you're doing. It allows us to do what we do, and it's awesome for the kids.
One of my goals in the future, Dr. Nolan, is to potentially put together sort of a one-day, almost like a one-day symposium on youth soccer with coaches and referees, and invite parents and talk about like what we've talked about on this podcast a little earlier about soccer development, what development means, age related, and then have a small section on identifying concussions and knee injuries and so on and so forth. So I think this is the first step in that dream. I can't thank you enough. I really appreciate you taking time out on your weekend. And I look forward to reconnecting with you, and would love to have you back on this podcast.
Yeah, I welcome the opportunity. I appreciate you having me. And yeah, the symposium, as long as I don't have to display a skill set, I think I'm too old at that point. But otherwise, I'm happy to be a part of that. That sounds great.
Sounds great, Dr. Nolan. Thank you very much again.
All right, thank you.